Welcome. I'm Gülşen Teksin Ünal, and now I'm working at Şişli Etfal Teaching Hospital. Metacognition in bipolar cases. First, I will talk about what metacognition is and what its target is. Metacognition controls cognition and evaluates. So it's a cognitive structure, information and process. It means that people are aware of their own cognition. Well, summarized it as a thinking, a way of thinking, and what we know and what we don't know. Metacognitive therapy is among the third wave of therapies. It is an evidence-based one whose effect and efficacy is proven in the treatment of mental disorders. Metacognitive therapy's main finding is instead of or rather than the content of cognition, but the reaction of people to these processes. Metacognitive therapy, metacognition, automatic thoughts, intermediate beliefs and schemes have all shaped metacognition. It's like a pyramid. So executive functions, self-regulating executive functions have three layers, and in metacognitive therapy there is a top-down approach. Theory is about cognitive attention syndrome, metacognitive beliefs, and for instance, cognitive attention syndrome is a cognitive system of thoughts, like monitoring threats, concerns, rumination, and focusing on traumatic cases. And as an example, I feel terrible. Why do I feel like that? I think I won't be better. I can't overcome anything. Everyone carries on, but I can't do that. Like, why did all these happen to me? Not the incident itself, but not they're talking about not the incident, but why it happened to him or her. This is a scale question comprised of questions. So attention in panic disorder is increased according to the symptoms, or in different, for instance, in trauma or post-traumatic stress disorder, it may be the attention derived from traumatic events. Rumination and concern are different. Concern focuses on future, while rumination focuses on the past. So concern tries to give meanings to things, and there is more self-esteem to solve problems, more motivating factors, and it lasts shorter than rumination. However, for rumination it's longer and less self-confidence for problem solving, and there is less motivation. Concerns can be controlled better than rumination. Cognitive beliefs. There are positive and negative metacognition or metacognitive beliefs. Here, for negative beliefs, for instance, a person has concerns for the future and believes that these concerns will protect him from the future, makes me more ready for the threats. And as an example of negative metacognitive beliefs, it's like I may get mad for overthinking, and these concerns, my thoughts may make me mad. This is a metacognitive, negative metacognitive thought. In metacognitive therapy, well, the negative ones are a little bit more persisting. There are 30 items in this scale. There are 5 subgroups. Positive beliefs, I gave an example, like concerns for the future may help me from, may protect me from the dangers, and uncontrollability and danger. For instance, when I start feeling concerned about something, I can't stop myself. So cognitive trust. It's like I have a poor memory and there's a need to control thoughts, like overthinking will make me mad, or if I don't think in a similar pattern, then I may be punished. Cognitive awareness is about focusing on the process of thoughts. It's like I'm thinking of my thoughts. These are effective in most of the mental disorders for attention and executive functions. A problem may be detected for anxiety.
Kaymış haldeydi ve bu nedenle kişiler etraflarından gelen her tür uyarını potansiyel bir tehlike gibi.
For anxiety disorders, people think everything as a potential threat. There are 2 cognitive modes. In one of them, you may think that incidents and cognitions are the same. However, in metacognition, this is different, and during therapy, metacognitive mode, when it is explained to the patient at the first stage, it is difficult, and lucid dreaming may be a good option. Lucid dream is that although you are in a dream, you can change your dreams within your dreams. This is an example, and that example can be given to the patient. In practice, BDT technique, we know that A is triggered by cognition or incident. B is cognition, beliefs, interpretations, and deductions. In metacognitive therapy, B is replaced by M. In ABC model, in metacognitive therapy, it's like AMC. So B is replaced by M in metacognition therapy. Techniques are similar to those applied in BDT. In both practices, there is conceptualization of the phenomena, guided discovery, Socratic questioning, but it has its own specific techniques for metacognitive therapy. For instance, dealing with metacognitive beliefs or postponing concerns or ruminations. A modification of attention, refocusing on attention. For instance, carry your thoughts with you. They are just like waves. They just sweep the shores. And if there are so many thoughts with you, you can put them inside a bag and carry that bag with you. Or think of an object and think of its color, size, shape. Is it smooth or rough? And is it shiny? Is it bright? So such attention exercise can be done, and while doing so, if thoughts come to your mind, do not get rid of them. And labeling, like will mom get sick, or am I worthless? So these are things that they are in the form of a thought. And there is the metaphor of television screen. Think of yourself as if you were watching you in a television program, and try to look at yourself from outside. Try looking at yourself from outside of the television. It is like putting some distance between the thoughts. Like while we are watching ourselves in the television, we can prevent some of our thoughts that are coming to our mind. Anxiety and depression, the efficacy of metacognitive therapy for anxiety and depression. This is a meta-analysis which evaluates results of 16 studies, pre-treatment, post-treatment analysis were made, and there is an impact of metacognitive therapy. When compared to waiting list and placebo, metacognition is found to be more effective, and compared to conventional BDT, it is found to be more effective. It can be found to be more effective. But although metacognitive therapy is good for treatment of depression and some other mental disorders, sample sizes are small, and this is a limitation. So anxiety disorder, depression, obsessive compulsive, and generalized anxiety disorders. For metacognitive model of depression, the person always watches the signs and symptoms of depression, and he thinks that watching them, monitoring them is very important. So he thinks that getting rid of emotions is very good. So if I think of reasons behind my sadness, then I can prevent this. Or what I did in the past is now being punished for the time being. For rumination, it can be used as an active coping mechanism, but this is not functional. In negative cognitive beliefs, depressive feelings and signs are not under control. I can't control them. Is there a problem in my brain? Is there an illness, disorder in my brain? So am I worthlessness? So in these cases, during rumination, the patient should be aware of that, and the depressive symptoms are indirectly increased as a result. Major depressive cases who attempted suicide, their metacognitions were investigated, were studied, and major depressive cases, 23 suicide attempts, 28 non-suicidal attempts. So cognitive trust is found to be higher in those who have not attempted suicide. In unipolar depression, there are so many overlapping factors of bipolar. However, there are different signs as well. This is a study where cognition is searched for unipolar and bipolar. 70 bipolar, 189 unipolar cases, 120 controls are included in this data. Automated thoughts scale and dysfunctional measure scale were used. In UP, BP, and control, they are more perfectionist. In the unipolar ones, automatic thought scale is higher than BP, and reappraisal, need for reappraisal is found to be higher in bipolar cases. This is a study on metacognitions and emotional schemes published in Comprehensive Psychiatry. 166 UD, 140 BD, and 151 healthy subjects were included. Metacognition scale was used, and the total score for UD and BD is no different, and but they are statistically significant when compared to the control group. So metacognitive model can be valid for depression. Metacognitive beliefs in unipolar and bipolar depression is compared in this study. Nordic Journal of Psychiatry, it was published in 2013. 51 UD, 45 BD, and 60 controls were included in this study. Negative metacognitive beliefs and thoughts control is different for control group and different for UD and BD. It's different for bipolar, different for depression. So in different subgroups, the results may be different, which means that we need larger studies. For instance, bipolar 1 type 1 disease should be differentiated from bipolar type 2 disease to get more explanatory results. This is a comparison of metacognitive disorders and control groups. 80 bipolar and 166 controlled were there. Apart from positive metacognitive beliefs, in all groups there is a statistically significant, and it's found to be higher. Thank you.